when it comes to this presentation, we are going to be seeing a lot of cases that I've seen in my relatively finite experience, and let's try to figure out how we can call these organisms in otherwise dubious clinical settings. So here we have a case. This is a 10-year-old girl presenting with fever, altered sensorium seizures, and behavioral changes. So, as I said, look at the history. So, we know she's encephalopathic. Now, I have provided with three onsets of images. So, the first time point, we have the diffusion. And in diffusion, as you see, there's multiple areas of diffusion restriction. As you can see, some of them are involving the subcortical white matter, quite a few in the periventricular areas. There's involvement of the thalamus as well, the brainstem. So at this point in time, we just know that it could be a vasculitic kind of pattern, it could be a starry sky a kind of pattern, not very sure. Cut to 3 days after the onset of clinical manifestations and, of course, the admission in the hospital, we now see florid involvement of bilateral thalami, and we do see the cortical subcortical areas now. Only these are quite striking as compared to what we saw at the initial time point. Cut to 15 days after the onset of hospital admission, we see that now all of the areas that were previously involved have undergone gliosis. And of course, there's quite stark cerebral atrophy as well, with new onset signal changes in bilateral cerebellum. With this in mind, I'm not sure if the audience can answer, but let's see, what would you call this? What would you call this pattern? Had you seen something like this in clinical practice? What would you call it? So the
Sorry
imaging
to
phenotype,
interrupt, Sabha. They
yeah,
can answer on the chat box, and
okay,
people
great,
are putting up
great.
the answers on the chat box. Yeah.
Okay, great. Yeah. So precisely what I said. So it's not wrong to call this an A&E like pattern. This is what we would call that, this kind of a picture in our daily practice, and it's absolutely fine. But with respect to A&E, the set of differentials are very limited. I'm sorry, just give me a moment. This doesn't seem to be working. For scrub. Now, you will be hearing a lot about scrub in my talk because we've been working on this for quite some time, and we've been able to elucidate some of the common, imaging patterns that could help us in identifying this differential as well. So, the teaching point here is that you could have a very, very strikingly similar looking pattern with respect to the neuroimaging phenotype, but you could have an absolutely bizarre organism pop up. And that is really the challenge with atypical neuroinfections. They don't just present atypically in terms of the clinical manifestations, but from what I've seen in my practice, they borrow patterns from other well known diseases. So instead of thinking organisms first, that's precisely why I go by these cases in terms of the pattern. So we will be seeing a couple of patterns that I have tried to elucidate over, my last couple of years in neuroradiology. So these are a bunch of patterns that I have seen that could emulate atypical neuroinfections. So we will be starting with rhombencephalitis, which is my first pattern, and also cereballitis. So now there are two cases here. Now, this is my first case. Essentially, what you see here, what is really striking is the florid, race perfusion in bilateral cerebellar hemispheres. Go back to the structural imaging, we do see that it's sort of flare hyperintense along the cerebellar folia. This dubious diffusion restriction, I really wouldn't call it that. But what I do see on post-contrast flare images is the enhancement along the leptomeninges, right? Now, this is case one. Now, this is a different case, but both of them have the same, pathogenicity in terms of which organ has afflicted, these patients. So in the second case, again, we see a cerebellitis kind of pattern where we see extensive involvement of bilateral cerebellar hemispheres, but we do see some areas showing true diffusion restriction, as is evidenced on ADC. And of course, in addition to the diffusion restriction, we see some areas of blooming as well. Essentially, these are microbleeds. And then we do see involvement of other areas of the brain, particularly the optic chiasma. We also see some involvement of the subcortical white matter as well as the thalamus. Now, again, let's keep this open to the audience. So, what would you call something like with this kind of a picture? Like I said, you will be hearing a lot about scrub in my talk because we've been able to elucidate some of the findings. Now, if you see, cerebellitis in the context of a very dubious clinical history where it's sort of subacute onset and you don't really know what is happening, one of the top differentials which I usually used to keep I still do, is autoimmune encephalitis. I always ask them to rule out viral encephalitis as well. But having seen a bunch of these cases, I would, prefer to keep a possibility of scrub, particularly in the context of microbleeds, because microbleeds tend to be sort of atypical for, of course, autoimmune encephalitis, and unless, of course, it is of paraneoplastic etiology. But with scrub, it's a relatively common finding. So with that picture, let's see another case. So now we have a 4-year-old boy, and this boy presented with, symptoms of a neuroinfection. So there's fever, there's meningeal signs. CSF, of course, the glucose is pretty low. So at this point in time, we know that we're probably looking at a bacterial infection, and it's lymphocytic predominant. And what we see on imaging here is, extensive involvement of bilateral cerebellar hemispheres. Of course, the signal changes here are very profound, and there is involvement of the subcortical areas as well. So like I said, for atypical neuroinfections, now these are not going to be organisms that are going to present in immunocompetent, run-of-the-mill, individuals who are absolutely fine. They're either going to appear in extremes of ages, or they are going to appear in the context of, say, occupational exposure, or have the patient having lived in certain areas in terms of the geography and the topography, where these organisms tend to reside. So these are the kind of this is the kind of clinical history that will actually aid you in terms of being able to give a differential of these disorders. Now, this case turned out to be positive for mycoplasma. So if we go back to our, microbiology, mycoplasma is something that I usually know, I relate mycoplasma to atypical pneumonias, particularly walking pneumonias. But in extremes of ages, like in this case, it's a 4-year-old boy. It did turn out to be, a neuroinfection where you see the affliction of this organism to the central nervous system as well. Now, this is another case where, like I said, in the previous case, I reiterated the importance of looking at the clinical phenotype of the patient presenting to you. So that was a case in extremes of age where we had a relatively younger kid, and now we have a much, much older individual. But here we have the history of type 2 diabetes mellitus. So we know at this point that this individual is massively immunocompromised. And then we look at the brain. Now, I wouldn't really call Listeria, an atypical organism, primarily because when I was in residency, I think one of the first things that I was taught by my absolutely brilliant professor was that anytime you see involvement of the brainstem and you're looking at an immunocompromised patient, think of Listeria monocytogenes, right? So if you see this, again, extensive fluoride enhancement of the brainstem, you see the involvement of the midbrain pons as well as it is extending down into the medulla as well. There's some amount of ventriculitis, supratentorial ventriculomegaly. So this, I would say, is not that much of a no-brainer, but we don't really see this as much in clinical practice, unless, of course, you have extremes of age. Having said that, Listeria is also one of those organisms that tends to occur in afflict the very, very, young kids, particularly the neonates. As we know, it's one of the commoner causes of neonatal meningitis.
I'm
So
sorry.
having said that, with respect, yeah, I'm
I'm
sorry.
sorry to interrupt. Some of the attendees are asking if you can please use the pointer. It's not visible sometimes. Yeah,
Oh,
now
is it?
now it's disappeared
Now
again.
it is visible.
Now it's visible, yeah. I think it
Let me
comes
just
and
use this.
goes. I'm sorry
Is
about
this
that.
is this better?
Yes,
I'm
this is
using the laser
yeah,
pointer
yeah,
here. Okay,
yeah.
great.
Thank you.
So having said that, with respect to rhombencephalitis, we usually relate it to, something like a Listeria monocytogenes. But like I said, there's been a lot that we've been able to elucidate in terms of scrub. And this is one of those cases where we found this rhombencephalitis kind of pattern that affects the brainstem as well as the spinal cord in cases of scrub neuroinfection as well. Now, the importance of picking on these diagnoses early or even giving the differential of such diagnoses is because the involvement of brainstem is a huge red flag. Your patient is not going to respond well. If you're going to, blanket therapy, of course, may or may not work, but giving a differential of these atypical organisms is really important in terms of being able to prognosticate the patient and also being able to deter them from further deterioration. So with the first few cases, I essentially wanted to, put forward this point that with respect to cerebralitis and rhomboencephalitis, don't just restrict yourself to viral, particularly in cases of cerebralitis, and of course the autoimmune encephalitis like etiologies. And of course, with rhomboencephalitis, there's a bunch of other viruses that can also afflict the brainstem. But do think of scrub, particularly in the context of, geography, which I will elucidate in some of the other cases as well. And like I said, geography really matters. Now, there's a particular, preponderance of certain geographical areas where certain organisms reside. For instance, there's a belt in Karnataka where, the patients present with scrub typhus infection. So we've been able to, in my clinical practice, when I know that, patient is not really responding to run-of-the-mill drugs, and I see an atypical like pattern, particularly like I showed you in the first case, where it starts off with say a vasculitis starry sky kind of an appearance, and then it sort of progresses to involve the thalamus, and sort of progresses to an A&E like pattern. I do like to give them a differential of scrub. Having said that, I will also say that when I do see just specks of involvement in the brainstem and sometimes in the periventricular as well as the deep white matter in tandem with microbleeds, I again think of scrub, because scrub does tend to have a vasculitic like pattern in the central nervous system as well as the rest of the body. And like I said, anytime you see the brainstem involved, it's very important that you go back and try to figure out what are we exactly looking at. Is it viral? Is it an atypical bacterial? Or is it something completely different? Because here the patient's prognosis is going to be terrible if we are not able to identify the organisms fast. Now we move on to the second pattern. Now this is track-based pattern. Now, what I really like about the track-based pattern is it's one of those instances where the beauty of this presentation really doesn't leave you. Once you've seen it, it's very, very difficult to unsee it. So as you can see, this is one of those cases where you have this beautiful, beautiful spread of the organism along the corticospinal tracts. Now, if you look at the structural imaging, you see extensive vasogenic edema involving bilateral centrum semiovale. Of course, here it is asymmetric. And then you do see this T2 hypointense, this kind of a flowery-like pattern which is spreading along the corticospinal tract, and some amount of microbleeds as well. But what's really striking is the post-contrast imaging, where you see nodular enhancement and the spread along the corticospinal tract. In addition to that, we did have some involvement in the spinal cord as well. So this, as we know, is the infamous tunnel sign. Now, I would say that, take tunnel sign with a pinch of salt, because I have seen a bunch of other organisms that do present with tunnel sign as well, some of which I will be showing in the coming slides. But in most or more often than not, the tunnel sign is associated with neuromelidiosis. So particularly with this organism, they tend to involve the corpus callosum, the corticospinal tracts, and as I showed, just spread along the CST in the cerebral peduncles as well. And like I said, a bunch of other differentials when it comes to the tunnel sign would also be sparganosis as well as listeria in some of the order cases. And like I said, it's important to elucidate the clinical history. Now, how do you exactly, what kind of a history do you ask in case of melidiosis? This is one of those instances where, again, when you know that, the patient is presented with something like this, it's got to be one of these. So this in fact was, doctor. She was a 20-year-old doctor who presented to us, an MBBS student who presented to us with, encephalopathy-like symptoms, and she had weakness as well. So we went back and asked for a history, and she had the history of a non-healing ulcer in the periphery. So much like most of the organisms that we know that sort of exhibit neurotropic mechanisms, so they are going to start off in the periphery, and there's going to be a retrograde spread. And this is one of those cases where it's beautifully demonstrated. Like you can see the retrograde spread involving the brachial plexus bilaterally. Of course, it is asymmetric and it is more obvious on the left, but you also see involvement of the spinal cord. And this, lady also had involvement of the neuroparenchyma as well. And what you see in the spinal cord is this extensive vasogenic edema surrounding this intramedullary abscess. So, intramedullary abscess, involvement of the brachial plexus could be a multitude of organisms. But when you go back and look for the right clinical findings, like in this case, because we have seen, a lot of cases of neuromelidiosis at our institution, we are also very privy to the fact that, these cases are going to be secondary to some kind of trauma, or they're going to have some kind of occupational exposure. But more often than not, most of these cases will have the history of a non-healing ulcer. right? So, and again, like I said, this is one of those patterns that sort of sticks into your head. So when a lesion respects the white matter tracks, it's always neuromelioidosis first. Of course, you could have a bunch of other organisms as well that could have present with this kind of pattern, but it's really important that you rule out melioidosis. And with what I've seen in my practice, some of these patients respond fabulously to treatment, but some of them, particularly the ones with, brainstem and spinal cord involvement, they have a pretty poor prognosis. So moving on to, a pattern that is very, very familiar to all of us, meningeal diseases beyond the routine. So the run-of-the-mill theory, the run-of-the-mill, mathematical formula when it comes to meningitis is that convexal meningitis is synchronous to pyogenic meningitis versus basal predominant is what you see in tuberculosis as well as fungal infections, right? And of course, you do see other telltales of these infections in the central nervous systems. You could have granulomas, you could have, exudates, etc., etc. But let me show you this case. Now, this is a 31-year-old female, fever, headache, just run-of-the-mill symptoms. She had neck rigidity. And the only thing that we found on CT as well as MR is convexal meningitis. Now, again, going back and, trying to figure out if this is just your run-of-the-mill bacterial or are we thinking about something different? Going back to the audience, let's see if you're awake. What do you think this is? Is it just, a pyogenic, or would you call it viral? Because we have had cases where, pyogenic, the convexal meningitis could also occur. Yeah, someone says parasitic. Okay, fine. What else? Because it's, of course, a presentation on atypical neuroinfections, we are thinking of other organisms. Okay, someone said GFAPs, there's pyogenic, there's viral. Okay, but this turned out to be positive for scrub. So, like I said, this is one of the first cases that I showed where there was involvement along the cerebella folia, and we did the ASL as well. Usually, this is one of my favorite sequences because when we aren't able to figure out what's happening, that really does help us in sort of tailoring our differentials. The ASL that I said. Now, with respect to this, I think it's very difficult to call it a scrub neuroinfection in the first instant, but when you see the, the CSF picture and it doesn't really match with pyogenic or viral, again, think of atypical organisms. So this turned out to be positive for scrub. So moving on. Oh, this is giving me some sort of trouble. Just give me a minute. Sorry about that. Now, this is the second case. So, of course, here you see some amount of basal meningitis. But in addition to meningitis, we see some areas of diffusion restriction in the supratentorial white matter. And in addition to that, we do see florid involvement of the, the small vessels, which is evidenced here in the form of microbleeds. So now, again, going back to the audience, what do you think we are seeing here? Which organism would show, microbleeds in addition to basal meningitis? So I'll give you some context now. This is, these are usually patients that have a history of trauma, or, there's raised intracranial pressure and they have CSF leak. And this kind of an organism, particularly this organism, has a propensity to affect the central nervous system in the context of CSF leaks. So we have fungal, we have HSV, we have aspergillus, amoebic. Um, let's just say these patients are not doing terribly well. They are still, some of them are just sitting in the comfort of their home and they have some headache happening here and there. Clostridium, Staph aureus. Okay, so this essentially is going to be a strep pneumo. If you go back and look at, the literature, you will find that strep pneumo has a propensity to affect particularly those cases where there are CSF leaks, some kind of skull-based defects, and on follow-up imaging, you see these extensive microbleeds. Of course, this is something that I have picked on after having seen these cases. I haven't really been able to call it strep pneuma at the initial instance, but now I know better. So what I wanted to, exactly say here is that with respect to meningitis, it is not just meningitis. Go back and look at what the initial time point imaging was, look at how the evolution happened. And in this case, the complications, especially when you see small vessel involvement in the form of microbleeds, the complications could define imaging, and that will actually help you in picking out which organism it could have been. Oh, I think I'm having a really difficult time with this. All right. Now, the fourth pattern is that of granulomatous and also mass-like lesions. Now, I wouldn't want to go into tuberculosis because I think we've all seen a lot of TB in our clinical practice. But I will say that having seen a lot of tuberculosis, we are also very, wary of the fact that in terms of treatment, if it's not responding to anti-tubercular therapy, we should think of other organisms. So let's have a look at this case. Here we have an 8-year-old female with fever and seizures. She was initially treated with anti-tubercular therapy. Now, particularly in the Indian subcontinent, it so happens that we know, there's going to be attrition. There's going to be loss to follow-up. Patients are not going to really going to abide with, the extremely long treatment plan. So we are very comfortable in calling tuberculosis, in calling something tuberculosis, particularly in the context of not being able to see any improvement on MR imaging with anti-tubercular therapy. We usually associate it with probably the patient is not really, abiding with the medical management, right? So this is one of those cases where for over a period of a couple of years, we kept incessantly calling it tuberculosis. And really, if you go back and look at it, it's not really wrong to call it a granulomatous infection. So if you see there's, extensive vasogenic edema, we see T2 hypointense, areas in the left parietal cortex. And in addition to the areas, we do see some amount of, bleeds on the SWI. And we also see enhancement. So really, we were quite surprised when it turned out to be something else. So when the patient didn't respond to anti-tubercular therapy and the patient kept worsening, at one point in time, neurologists, they gave the case up to the neurosurgeons and asked them to actually go ahead and perform a biopsy. And it turned out to be a case of cerebral sparginosis. Now, I told you of a tunnel sign where, in terms of melioidosis, we see the extension of the organism along the corticospinal tracts. Now, this is one of those cases where the tunnel sign could help us in predicting that this could be a parasitic infection. So if you go back and see here, I hope my arrow is visible. Let me, yeah. If you go back and see here, we actually see that the lesion is towards the far end, towards the convexity, that is towards the bone. So essentially what I'm trying to say here is, with respect to parasitic infections, one is, you're able to actually track the course of the lesion. Like in this case, you're able to see now this is exactly how the lesion course, from the periphery to the center. The other thing is on follow-up imaging, you do see some areas of the brain that were previously uninvolved are now involved, which essentially means to say that it is, of course, disease progression and the fact that the parasite could have migrated. So these are your telltales in terms of how you could predict that, it could be a parasitic infection and not your run-of-the-mill tuberculosis. So moving on, again, this is giving me some trouble. Sorry about this. Yeah. Now, this is a giant tuberculoma. Now, this is something that is, I think, everyone, each and every one of us, particularly in our residency, we've seen at least one of these beautiful cases where we see the giant tuberculomas sitting in the brain. And like I said, I didn't really want to speak much about tuberculosis per se, CNS tuberculosis, but I wanted to show this case because, like I said, we are very, very comfortable, particularly in the Indian and the Asian subcontinent, calling something tuberculosis. But it could sometimes work against us as well. Now, this is a case of run-of-the-mill classic intracranial tuberculomas. Now, what we see here is, this giant lesion, which is T2 hypointensity, showing that the concentric pattern that you see here. Some of us call it the tree bark like pattern. We're very, very comfortable giving all of these signs. But really, what's important here is that you see the peripheral rim of enhancement. And of course, you see the lactate peak as well. But what's really, really striking is the fact that despite it being such a large lesion, there's absolutely no, elevation of perfusion along the rim. So now this case was that of a 20-year-old female who presented to us with dubious symptoms. Now, she was relatively doing well. She just had headache for the past couple of months, and we got the MR, and we were very surprised that we saw this lesion sitting in the pons. And we saw this T2 hypointense lesion sitting here. There's some amount of vasogenic edema. Of course, this is concordant with the size of the lesion. But what we really picked on was this eccentric kind of enhancement, and of course, there's some amount of rim enhancement as well. There was no diffusion restriction, there was no microbleeds, no calcification. So we were quite comfortable, like I said, calling it, say, a tuberculoma. We did think it could be a toxo, but there was absolutely no evidence of immunocompromise in this patient. And since she was doing pretty well, we thought, why not just, follow her up? But in the follow-up imaging, we performed, perfusion, because we thought that an insidious history with such a large lesion sitting in the brainstem is not in keeping with an infection, right? So we were smarter. At the follow-up, of course, we got the perfusion, and we saw this massively raised perfusion, and we sent the patient up to the neurosurgeon. So this turned out to be a case of glioma. And I will say that, particularly in the context of giant tuberculomas, it's not very uncommon that you have a presentation very, very similar to gliomas. So this is where, of course, again, your perfusion really helps you in sort of picking out what could be, an infection and what could be a tumor. Secondly, the MRS is, of course, very likely going to help you in being able to differentiate, one from the other. And of course, the clinical history. Infections rarely have a very insidious, clinical history. Of course, I will say that a lot of patients presenting with, CNS tuberculosis, they do have sort of an insidious onset as opposed to other organisms. Now, this is very interesting case. So this was the case of a 55-year-old man that came to us with, again, the clinical history, not very helpful. He had some bulbar symptoms and there was ataxia. So we looked at the brain and we thought, okay, there's involvement of the cerebellum, there's involvement of the brainstem. So we know it's sort of matching with the clinical picture. The onset, of course, here was over a couple of weeks. And we got the, post-contrast imaging. And of course, we saw, enhancement in the areas that showed involvement on the T2 weighted images. And we got a spine screening, and we were very surprised. We saw this extensive involvement of the spinal cord as well. There's extensive white matter changes, intramedullary signal cord changes in the spinal cord, and white matter changes in the supratentorial neuroparenchyma. We do see this dot-like enhancement in the spinal cord as well as the pons. Now, at this point in time, I will say we were very, a bunch of us were thinking along the lines of, could it be clippers? Could it be slippers? And we thought, let's just call it one of the other. And we thought it could be one of those. Some of us even thought, could it be a very different, very, very presentation of GFAP? Of course, I was not in very much in favor of GFAP, but I did call it clippers, and we sent the patient up back to the the neurologist, and the patient did respond well to steroids. But cut to a couple of months later, the patient came back to us, and there was florid increase in the signal changes. And at this point in time, we didn't know what was happening. So they performed a bunch of clinical tests, laboratory tests, and this turned out to be positive for histoplasma. The urine antigen turned out to be positive for histoplasma. Particularly, again, in the context of geography, I would say that histoplasma is something that we relate to what happens in the United States. Of course, when we see, when we know, if they are cave explorers, those kind of things, that is when we relate to in terms of histoplasma. Now, I have absolutely no history, no travel history from this patient, but this is just one of those cases where it turned out to be positive for a granulomatous infection. And what's really important is that we go back and try to look at what could have helped us. So we have really bright residents at NIMHANS, and we went back and looked at the imaging again when we figured that, okay, this is actually a granulomatous infection. And one of our very bright residents really picked on this and said that, ma'am, come back and look here. This is actually a ring enhancing granuloma. Now, what initially we thought were just dot-like enhancement and inflammatory actually turned out to be granulomatous. But I will say that this is not one of those cases that I will be able to diagnose with a lot of confidence in my daily practice. Of course, when the patient is not responding well and keeps coming back to you, that is when we try to think out of the box and think of atypical organisms. And this is a running joke, I think, in the Indian subcontinent, that everything mimics tuberculosis and tuberculosis mimics everything. So with that, I will move on to the next pattern. Now, again, abscesses are something that we are very, very privy with. We see a lot of abscesses in our daily practice. Now, of course, this is the synquinolone of pyogenic abscesses, that is where you have the dual rim, where you have the inner key sachet, then of course you have the granulomatous inflammation that you see, and then the outer rim that shows deposition of paramagnetic substances, particularly iron. And this is something we all know, but let's have a look at what happens in the context of patients that are immunocompromised and they present to you. So now this is really not a very difficult diagnosis to make. You look at it and it's a pyogenic abscess. You look at the MRS. Of course, you look at the lipid lactate peak. You see the cytosolic amino acids at 0.9, and then you see something at 2.4, and now you're thinking, oh, I'm looking at a succinate peak. Am I looking at an anaerobic infection? It's possible. It's possible, right? So we call it a pyogenic abscess. And we thought, okay, we are done with it. But then we went back and, the clinicians came back to us and they said, this patient has actually turned out to be positive for two organisms. And the very first question I asked when they mentioned that was, what is is the patient immunocompetent or is he immunocompromised? So this was a case of tuberculosis, of HIV, and it turned out to be positive for nocardia as well as staph aureus. Now, again, like I said, with respect to what we see on MRS, it can really, really help you in picking out what the organism is that has affected the central nervous system. So when you see an imbalance between, succinate and acetate, you're looking at a mixture of anaerobic organisms. Now, nocardia, of course, is an aerobe, and staph, it could be a facultative anaerobe. Now it's really not important that you pick on the exact organism, right? You just call it a pyogenic infection. They're going to run the culture sensitivity. In some cases they actually go and drain if the patient is not doing fabulously well in terms of the clinical manifestations. Our neurosurgeons even go back and drain, and then they perform the culture sensitivity. But it's important that we try to learn from these experiences, right? So we went back and we looked at the literature and we tried to find out, is there any way that we could have predicted this to be nocardia? And lo and behold, we did find literature that said that when you have sentinel abscesses and also involvement of the overlying meninges, like in this case, you could think of the possibility of atypical organisms, particularly in the context of HIV. It could be a nocardia. Of course, now the important thing is I'm a neuroradiologist, but I think it's very important for me in terms of both the diagnostic and as well as the intervention aspect, that I look at the whole body. So when I look at something that has affected the central nervous system, I have to go back and look at the rest of the organs. So we did go back and look at the chest here, and there was abscesses in the chest as well. If you go back and look at the literature on nocardia, you will see that nocardia is very, very notorious to affect the lungs as well. So moving on now, this was a patient that presented to us with spinal cord compression symptoms. Now, really, if you look at it, it's not a very, very difficult diagnosis to make in terms of what we are seeing here. It's just going to be one of those cases where you define what's happening, right? So you look at this here and you see it's a peripherally enhancing lesion which is epicentered in the epidural space. We of course we went and tailored the sequences. We got the diffusion here because we knew with the peripheral restriction we were probably dealing with an infection. So we see the floral diffusion restriction, so we know at this point that it is an epidural abscess. But what's so atypical about this? So really, this turned out to be positive for brucellosis. Now, with neurobrucellosis, I would say again, go back and ask the clinical presentation of these patients. So if they give you the classical undulating pattern of fever, that's when you know you're thinking about along the lines of brucellosis. Now, again, the other important thing with neurobrucellosis is these patients tend to have some exposure to, say, unpasteurized milk or some exposure to cattle. So that really will help you in terms of being able to call it a brucella infection. Of course, I would say that in the Indian subcontinent, it's not a very atypical infection. We do see involvement of particularly spinal cord involvement of brucella quite often. So it's not really that atypical. So yeah, like I said, this was one of those cases of brucella involving the epidural component. I will say that with respect to how it involves the central nervous system, some of these cases, particularly because they have this relapsing remitting kind of pattern, we do tend to think along the lines of, say, a multiple sclerosis. Now, these patients are not going to be floridly infective; they're not going to be toxic. Like for instance, your fungal or your amoebic cases are